We will be moving on to the first symposium of the day, which is on breathlessness in pregnancy. Moderator for the session is Dr. Achinta Disanayaka, and I'd like to call upon the following dignitaries onto the stage. Dr. Amila Rubasingha, Dr. Dilesha Vadasingha, Professor Duminda Yasaratna, Dr. Sachini Senaviratna, Dr. Bodhika Samarasekara, and Dr. Achinta Disanayaka.
Right. Okay, so good morning to you all. So we're starting the first session, which is on breathlessness in pregnancy. Without wasting time, I'd first like to welcome the panel. And the first lecture will be delivered by Dr. Amila Rubasingha. He is a consultant obstetrician and gynecologist at Disoisa Maternity Hospital. So he'll be touching on the obstetric complications due to respiratory disease. Amila.
Good morning. So I'm Amila from the Disoisa Hospital. So the task upon me is to lay the groundwork for today's symposium or discuss why and how respiratory conditions process challenges in obstetric management. So I think this slide was dealt in the previous lecture, why the topic is important. Respiratory diseases have been the third commonest cause for the maternal death in 2020 in Sri Lanka. And this is from UK. During the COVID pandemic, it was the commonest cause for maternal deaths, the indirect commonest cause for the maternal deaths in UK during the COVID pandemic. And as we all know, the disease conditions, there's a vast spectrum and different pathologies, so approach will be a little bit difficult as well. But when there's a disease, respiratory disease complicating pregnancy, we have to think about the effects of the disease to the pregnancy and the effects of the pregnancy to the disease. And then there will be effects of the disease to the fetus and offspring as well. So, how pregnancy complicates things? There will be diaphragmatic splinting from the enlarging gravid uterus, and there will be anterior posterior diameter of the chest wall will increase up to 5 to 6 centimeters during the pregnancy, and the lung compliance will be reduced during the pregnancy. So therefore, as it's obvious, the ventilation is more difficult. And with a disease condition, this condition can be further severe. And then, during the fetal-placental unit, the increased oxygen consumption will be there. Usually there will be 20% increase, and this will be further increased during the labor. And due to the progesterone-mediated carbon dioxide washout, reduced buffering capacity of the blood will be there. So with the combination effect, if there is a threat to the physiological status of the pregnant mother, there will be accelerated development of the hypoxia and acidosis. So patient will deteriorate quickly, and the requirement for ventilation will be more frequent compared to the non-pregnant women, and mechanical ventilation will be difficult compared to the non-pregnant women. Next, due to the effects from the estrogen, there will be hyperemia and edema of the upper airway tract, and then that will cause difficult intubation, and ultimately resuscitation will be more challenging, and difficulties will be further exaggerated by effects from the gravid uterus, caval compression, and maintaining the saturations. So the other thing I want to highlight is the effects coming from the pulmonary edema. As we know, the stalling forces are changes during the pregnancy. There will be reduced plasma oncotic pressure due to the hemodilution, and plasma volume will be increased due to the effects from the cortisol. So capillary permeability will be changed, and pulmonary pressures will be high. So pregnant women are more liable to develop pulmonary edema, and especially in a patient with a previous cardiac condition, they are having a higher tendency to develop pulmonary edema. And even in a patient who are not having any previous cardiac issue or low risk patient, during the intrapartum management, fluid overload and oxytocin can cause pulmonary edema. next comes acute respiratory distress syndrome or ARDS, which is part of the same spectrum. During the pregnancy complications make patients are more liable to ARDS. So it can be things like preeclampsia or acute fatty liver disease of pregnancy, or amniotic fluid embolism, which are specific for pregnancy, and also pregnancy-associated events like septic abortion, choraminitis, or gastric aspiration due to changes in the esophageal sphincters and bowel emptying due to the progesterones. And on the other hand, we can't forget about effects comes from the immune deficient status in the pregnancy. So there will be definitely reduced cell-mediated immunity, which causes risk of severe pneumonia, and pneumonia can occur due to atypical organisms and it can be disseminated. In the same time, complications of pneumonia like empyema things and septicemia will be more prevalent in pregnant women. So when there is a disease which maternal medical complication, we think about its cause during the pregnancy. For an example, if you take asthma, the cause is unpredictable, and 1/3 of patients will have severe relapses during the pregnancy period. On the other hand, pathologies like sinusitis will be 6 times more common during the pregnancy. So, in the same way, when it comes to our care, these pregnancy changes will pose us as a challenge in diagnosis as well. So 50% of pregnant women will have some sort of breathlessness. So when a patient comes to us, we don't know whether it's due to the anemia or whether it's physiological or whether we are dealing with the pulmonary embolism. In the same time, test parameters will be changed and difficult to interpret. For an example, our reference ranges for the ABG will be different from a non-pregnant patient, and we can't use protein D dimers for the diagnosis of pulmonary embolism. So the next issue comes with limitations in medication uses. So due to the effects towards the pregnancy and especially towards the fetus, we can't use most of the routine drugs. So tetracyclines like doxycyclines and streptomycin, which we use in tuberculosis, are obviously contraindicated in pregnancy. In the same time, there are arguments about safety of steroids, and it also causes worsening of gestational diabetes mellitus. And immunomodulators like MTX, methotrexate, or cyclophosphamide are generally avoided in pregnancy. In the same way, our routine medication which we use in the management of pregnancy, like in a case of PPH as a life-saving measure, we use carboprost, and it may cause severe bronchospasms in a patient with ergometrine. And there are concerns about ergometrine as well. In the same way, for the pain relief, we can't use morphine. I mean, we can use, but with a reservation, and we may prefer fentanyl over morphine. And in a patient with low dose, in a patient with bronchial asthma who is not being checked for sensitivity, we are a bit reluctant to use low dose aspirin to prevent preterm severe preeclampsia. So these things will manifest in our management, and also the ultimate effects to the pregnancy. For an example, if we take asthma, if the disease condition is well controlled, what we know is the outcome of the pregnancy is equal to patient without asthma or a healthy patient. But in a poorly controlled patient, asthma will cause miscarriage, low birth weight, and increased C-section rates. And there are data which suggest it may increase preeclampsia risk as well. And interestingly, this situation occur due to the chronic inflammatory situation rather than the hypoxic status. And in the other hand, when it comes to the pneumonia, apart from the maternal complications like bacteremia, empyema, and pneumothorax, in the pregnancy it can cause us increased rates of placental abruption, preterm labor, preterm delivery, and neonatal morbidity will be increased up to 12%. And if the disease is coming from a pathology like varicella, there will be concerns about newborn infection as well. So like this, we have summarized about the effects of pregnancy and why we are concerned about respiratory pathologies during the pregnancy. And over to you, Dr. Chin. Thank you.
Right. So thank you, Amila. We'll have a small session at the end of the session for you all to have questions. I again earnestly ask you all, if you all have any questions, this is a good opportunity to ask questions, but we'll have a session for questions at the end of the symposium. So thank you, Amila. So I would like to now invite our second lecturer. She's Dr. Dilisha Vadasinghe. She's a consultant pulmonologist and senior lecturer at the Faculty of Medicine, University of Kelaniya. So she'll be talking about the physiological changes in pregnancy with regards to the respiratory system. Right. Over to you.
Thank you. I would like to thank the College of Pulmonologists and the Sri Lanka College of Obstetricians and Gynaecologists for inviting me today to doing this lecture. I've been given a bit of a boring type of a lecture, but then anyway, I will try to make it as interesting as possible. Physiology is always, if you understand the basics, you can work out a lot of things. So my task is to set the platform for the next two speakers, and I hope you'll be able to understand the basis behind what we are going to talk next. Right, so my talk will outline the chest wall and the lung mechanic changes, the changes in lung volume, the changes in lung function test, and the blood gases during pregnancy. Right, now all of us know that there are chemical or the hormonal changes happening in pregnancy, mainly due to the changes, increased progesterone, estrogen, and prostaglandin secreted. So with this progesterone secretion, it triggers the respiratory center. We know in the medulla we have the respiratory center. So it triggers the respiratory center by increasing the sensitivity of the respiratory center to carbon dioxide, which is the normal drive of respiration. So this is seen because of through a steeper slope, so I'm not going into those details, right? And also it alters the smooth muscle tone of the airways and results in a bronchodilation effect. So there is bronchodilation due to progesterone, there is increased respiratory drive, and also hyperemia, edema of the mucosal surface causing nasal congestion also happens. You remember in the previous talk we were talking that the nasal congestive symptoms are very much higher in pregnancy. So this is the reason why it is. And estrogen increases the number and the sensitivity of progesterone receptors within the hypothalamus, the medulla, and the central neuronal respiratory related areas, so that it enhances the effect of progesterone further. And also prostaglandins, there are various types of prostaglandins being secreted. So they cause bronchial smooth muscle constriction, and some causes bronchodilator effect. Now moving on to the physical mechanisms, what happened? You know that the upward displacement of the diaphragm starts happening with the growth of the uterus. And therefore, the anterior posterior diameter of the thoracic cage would increase. How does that happen? So let me get the pen here. Right, here you can see that the diaphragm is pushed up about 4 centimeters. When the diaphragm is pushed up to allow the content, the anteroposterior diameter of your thoracic cage, of the pregnant mother's thoracic cage, would increase, right? That is to maintain a fairly normal total lung capacity, right? But the diaphragm function is not impaired. It functions normally, but only it is pushed up further. So it is the thoracic cage circumference, anteroposterior, the circumference would increase by about 5 to 7 centimeters in circumference, and this will result in the mechanical effects we see, especially the changes in lung volume mechanics. So what happens due to the enlarged uterus? As I told you, the end expiratory abdominal pressure is increased, right? Therefore, the diaphragm is displaced upwards, and also because of this, the negative pleural pressure starts increasing, and therefore the transpulmonary pressure, that's the pressure within the alveoli and the pleural space, starts to decrease, and therefore the peripheral airways starts collapsing. Therefore you get a reduced functional residual capacity and expiratory reserve volume. You know, everybody knows that the functional residual capacity reduces. FRC, expiratory reserve volume reduces, residual volume reduces. But why is that? It is because of this mechanism, what happens in the lungs, right? And also, though the chest becomes shorter, it becomes increased in anteroposterior diameter. Therefore, the total lung capacity will remain constant. So this is another diagram showing the changes in lung functions, right? Here you can see the spirometry usually remains unchanged, right? So your FEV1, FEC, your peak flow, the ratios will remain the same as a non-pregnant individual. But the lung volumes in contrast or in converse will have a significant change. So as I told before, the end expiratory reserve volume will reduce by about 80 to 40% depending on the stage of your labor and also the stage of pregnancy. And the residual volume will reduce from 70 to 22%, and the functional residual capacity will reduce from about 10 to 25%. And what increases, right? The inspiratory capacity, you can see here the inspiratory capacity means the tidal volume plus the inspiratory reserve volume. So this part is the inspiratory capacity. So the inspiratory capacity compared to a non-pregnant mother will increase because the tidal volume increases, therefore the end inspiratory capacity will increase. The tidal volume here we can see increases, and that is because of the respiratory drive, increase in respiratory drive as I told before. And the total lung capacity will not show much change, and the vital capacity is the maximum air you can expire after a full inspiration to the residual volume. So that is from here to here, it's more or less remaining unchanged, right? So those are the changes in lung volumes in pregnancy. This is just another diagram showing it. You can see that the total capacity will remain stable or slightly reduced, but the vital capacity will stay unchanged, right? And the residual volume will decrease, expiratory reserve volume will decrease while the tidal volume increases. So what happens to airway resistance, right? So during pregnancy, progressively the airway resistance will start decreasing. So the total pulmonary resistance is said to be decreased by about 50%. And this is due to the hormonal induced relaxation of the tracheobronchial tree. Remember I told you previously, right? And then the diffusing capacity, the compliance does not change. The minute one ventilation I told you will increase by about 30 to 35%. The maximum voluntary ventilation there but will not decrease, will not change. To remember, how the minute ventilation is increased here is mainly by the increase in the tidal volume. The respiratory rate will remain more or less normal during pregnancy. So your respiratory rate will not change to increase minute ventilation. It is your tidal volume which will increase. So because the patient breathes very fast and deep, right, even in the normal respiratory rate, there is alveolar hyperventilation happening because the consumption of oxygen is not increased as much as the increase in minute ventilation. So what happens due to alveolar hyperventilation, right? So you start washing out a bit of carbon dioxide. So if you look at your blood gas, your carbon dioxide level will be about 27 to 32. We know 35 to 45 is the normal in normal people, but this is the normal for the pregnant mothers. And the arterial pH maintains at a slightly alkalotic range, 7.40 to 7.45, and the bicarb due to the renal compensation drops down to about 18 to 21. So this will be the normal blood gas values which you should use to interpret your patient. Due to the time constraint, I will not go into more about this dyspnea in pregnancy, but it will be talked in the next session. So remember, I told you about the upper airway congestion. So the increased tidal volume is perceived as breathlessness in some of the patients, where still their respiratory rate is normal, their lung mechanics are more or less fairly within the normal limits, but they will perceive breathlessness in pregnancy, right? So, but still you should know that if the respiratory rate goes above 20, PCO2 goes less than 30 or greater than 35, patient is hypoxemic, then we know that there is a problem in our patient. So to summarize, there are chest wall and lung mechanic changes, changes in the lung volumes, and changes in the lung function tests, which we should be very careful when we are interpreting our patient's symptoms. And also the blood gas values. So the PaO2, the oxygen levels will be slightly elevated than normal. PCO2 will be slightly low. There will be a metabolic alkalotic, respiratory alkalotic type with a slight decrease in bicarbonate levels. Okay, thank you very much. And at the end of the talk, if there are any questions, I am happy to take. Thank you.
Okay, thank you, Dilisha, for your presentation. So the next lecture will be delivered by Professor Duminda Yasaratna. He's a consultant respiratory physician at Teaching Hospital Peradeniya and also serving at the Department of Medicine at University of Peradeniya. So he'll be talking to you how to clinically evaluate a patient who comes with breathlessness in pregnancy. Over to you, Duminda.
Thank you for the introduction. So my task is to talk about clinical evaluation of breathlessness in pregnancy, a little overview. And next, Sachidi will talk about the investigations. Right, so breathlessness is common, and actually it's more common than we think. This is one early study done in 1978, published in British Journal of Obstetrics and Gynaecology. A small study of 62 mothers where they have found that by the gestational age of 30 weeks, about 78% of mothers are having the symptoms of breathlessness. So that would of course involve the perceptions, not true dyspnea, but as Dilisha mentioned, the perception. So anyway, it's very common. So what they have mentioned is this breathlessness starts in the first trimester itself, and by about 15 weeks, it doubles from 24% to 48%. Then there's a gradual increase in breathlessness towards during the second trimester to reach the 78% during the early third trimester before it going into a plateau phase. So that was a very early study with small numbers. Later on, the large surveys has also confirmed that about 2/3 of pregnant mothers are having this subjective breathlessness. And about 20% of them are having dyspnea at rest as well. So the common causes of breathlessness are, one is, as mentioned, the physiological breathlessness, which is the most common. Then respiratory causes including asthma, which is the commonest. Then pulmonary embolism, respiratory infections. Then cardiac causes, metabolic causes, and drug-induced, as mentioned by Dr. Amila in the first lecture, and also psychogenic causes. So the physiological breathlessness, as mentioned, starts in the first trimester, and there's an increase towards the progression of the gestation. Since it starts at the very first trimester, it's not the gravid uterus. Most likely, it is the physiological, the biochemical, and mechanical changes, as mentioned, that contributes to this physiological breathlessness. So it's a diagnosis of exclusion, where the patients are usually they are having breathlessness, but they don't have any wheezing, cough, or on examination there are no crepitations or rhonchi. So it's basically other history and examination would be largely normal. Where you have to exclude other common causes like pregnancy-induced asthma, where the patients are having recurrent cough, wheezing, nocturnal dyspnea, or like other causes like pulmonary edema or pulmonary embolism, where the patients would have acute breathlessness, then features of heart failure orthopnea, paroxysmal nocturnal dyspnea, and also on examination there can be murmurs in the heart, cardiac murmurs. And so these are the common differential diagnoses where you have to take a detailed history and examination to exclude the other differential diagnoses before diagnosing clinically dyspnea in pregnancy. Of course, you might need some investigations also. You might not be able to diagnose by history and examination alone, which will be discussed later. A few words about asthma in pregnancy, which is quite common, 4 to 8% of all pregnancies. In US, they say it's more than 8%. The classical teaching is that 1/3 of asthmatics would improve during pregnancy, 1/3 would worsen, and another 1/3 would remain stable. However, this 1/3 that exacerbates, so increases the asthma during the pregnancy, partially it is because that patients don't take their drugs. They stop inhalers, they stop their medication. And newer studies have shown that it is not actually 1/3, it's around 19% that truly worsens during pregnancy. And when they worsens, typically that happens between 29 to 36 weeks, so towards the latter part of the second trimester and early third trimester. And classically, they are okay during their labor and delivery. So the asthma does not much exacerbate during, but it's not in everyone. And also, usually after 3 months after the delivery, they are back to their normal status. And also, when they experience asthma during one pregnancy, they have a tendency to have recurrent symptoms during their subsequent pregnancies as well. Pathophysiology seems to be complex and we have not fully understood, but there's a shift of the immune response from T helper 1 to T helper 2, which exacerbates asthma or which contributes to asthma. And also, as mentioned by Dilesha, there's mucosal and laryngeal edema, and also there are other placental hormones that might contribute towards the pathophysiology. The symptoms, triggers, and signs would not be much different from non-pregnant patients. They would have episodic wheezing, dry cough, breathlessness, and chest tightness when you take a proper history. The triggers would be like the cold weather, dust, and other psychological factors would also be there. And of course, you might hear some rhonchi and with prolonged expiration. Thought of sharing very quickly some of our local data. This is a survey of 500 plus 539 patients, 539 mothers, and we at Peradeniya, we found that 41 mothers are having asthma in pregnancy. That is also a questionnaire-based survey. So our prevalence was 7.6%. And very interestingly, out of these 41, 38 had pre-pregnant asthma. So there were only 3 new asthmatics during that cohort. A pre-pregnant asthmatic would have a risk of around 60% in developing asthma during pregnancy in that cohort. And the new onset asthma among non-asthmatics was very low. However, this was not a randomized sample, so we need more studies to look at this real data. And also, when they develop asthma, it was interesting to see that majority develop asthma in the first pregnancy itself, and there was a trend to recur that in subsequent pregnancies. That's about asthma. What about pulmonary embolism? Though there will be more lectures on pulmonary embolism. So there it is again, there are multiple risk factors, maternal, fetal, and placental risk factors. So they would usually present with acute onset chest pain, breathlessness, cough, tachypnea. So if the embolism is massive, submassive, or even large embolism, there will be very significant symptoms, and it's not difficult to diagnose. But small pulmonary embolisms might be very difficult to diagnose, especially with the physiological changes in pregnancy. Patients would attribute those symptoms to physiological changes and might go undetected. So these, what do you call this, testing scores are not validated for pregnancy, but there's a pregnancy adapted Geneva score where you look at age, past history of surgery, past DVT, unilateral lower limb pains, hemoptysis, and lower limb tenderness, so similar to other Wells scores and tachypnea, but some of these things are not easy to diagnose, especially looking at DVT, because if it's a peripheral DVT, yes, you would be able to see, but sometimes these patients might be having iliac vein thrombosis in pregnancy, so which is not easy to clinically diagnose, or even with ultrasound scan, it might not be easy to diagnose. So very small pulmonary embolism sometimes becomes a diagnostic challenge. I'll briefly talk about cardiac conditions because we are not discussing these things in other lectures. undiagnosed cardiac conditions are not uncommon to diagnose for first time during pregnancy. The most commonest would be valvular heart diseases like mitral stenosis or undiagnosed pulmonary hypertension, which might even be primary pulmonary hypertension. So these patients typically they present during the late second or third trimester, where the demands, the cardiovascular demands are getting higher. And of course, they would have symptoms of heart failure or cardiac symptoms, orthopnea, paroxysmal nocturnal dyspnea, exertional breathlessness. And when you examine, of course, you would find features of pulmonary hypertension, loud pulmonary second heart sound sometimes, and also cardiomegaly with valvular changes. So they usually present during second, third trimesters, and sometimes lower limb edema, gross heart failure features also might be there. Okay. Puerperal cardiomyopathy is a new onset cardiac complication that would be usually that occurs during the very last phase of the pregnancy or in the postpartum period. So again, they present with features of heart failure, the classical dyspnea, paroxysmal nocturnal dyspnea, and they would be tachycardic with edema. There would be left ventricular dysfunction with heart failure signs and symptoms. So 1 month prior to delivery and up to 5 months after the delivery, that's a classical period. Most patients, they present postpartum, and there are these risk factors as mentioned in this slide. So they would have fatigue, low limb swelling, cardiac cough and chest congestion, chest pain with palpitations. So in summary, dyspnea in pregnancy is multifactorial. It can be, there are a lot of differential diagnoses, and there will be a lot of overlaps clinically. The symptoms and signs sometimes very difficult to diagnose on clinical grounds alone. The timing, whether they come in the first, second or third trimester, as mentioned in this slide, would help us to come to a differential diagnosis. Anemia also common, and also amniotic fluid embolsum can occur during the delivery, and also infections would also be a cause which will be discussed in subsequent lectures. So clinical history and examination is very important. However, you might not be able to diagnose with them alone, and you will have to go for investigations also. With that, I will hand over to Sachini to discuss about investigations. Thank you.
Thank you, Dubinder. So thank you for keeping to the time and covering all the bases. So next I would like to invite Dr. Sachini Seniviratna. She'll be talking, so we covered the physiology and then how to clinically evaluate. So Dr. Sachini will explain how to investigate a patient with breathlessness in pregnancy.
Thank you very much. And I would like to thank the Sri Lanka College of Obstetrics and also Sri Lanka College of Pulmonologists for giving me this opportunity. So my task has been made easy by Dr. Dilesha and Professor Asaratna. I will talk to you about investigating breathlessness in pregnancy. So now, as mentioned previously, it's a very common symptom. And it's always difficult to tease out which is pathological and which is physiological. This is a day-to-day referral that we all receive, a number of referrals every day, and each referral is a challenge. So we appreciate you guys for actually referring these patients for us, because it is actually a very difficult clinical question. Right, so whom do we investigate and how do we do that? So when it comes to investigations, while in pregnancy, what we have to think about is the safety in terms of maternal and fetal health. And obviously from the mother's perspective, they're always very worried about the fetal health and the possible fetal outcome at the end. But as practicing clinicians, we are always more concerned about the maternal safety. So it is a bit of a balance, and that is where the history and examination really helps us. Okay, so the history and examination really helps us find out whom to investigate further and whom not to, right? And because of all these physiological changes that was explained by Dilesha, there are errors and challenges in interpreting certain investigations, and also there are some misnomers within the medical community about utility of certain investigations. Okay, So this I will skip. So this is basically the repetition of the physiology. So what you have to understand is that progesterone is the main driver to increase the tidal volume and minute ventilation during pregnancy. And also, as mentioned by Dilesha, there's a reduction in the functional residual capacity and the expiratory reserve volume. Right. So this physiological breathlessness, as mentioned by the previous speakers, is mostly a sensation of breathlessness. So the exercise capacity of a pregnant woman essentially remains unchanged, right? So, but we all know that they do feel this sensation of breathlessness, and it's a very common complaint. But like an objective assessment, one of the basic things that you can ask is like about their exercise tolerance. So a pregnant woman at term should be able to climb a flight of stairs at a stretch without stopping, even if she has to catch her breath at the top. Okay, so she shouldn't have to stop in between to catch her breath. So that indicates that they have a preserved exercise capacity during pregnancy. Right. So these are broadly the investigations that I would like to speak about: lung function test, arterial blood gas, chest X-ray, CT chest, D-dimer, and CTPA versus VQ scan. Right. Okay, so spirometry. So this is one of the basic respiratory investigations, and it gives us a wealth of information, right? So particularly in finding out obstructive airway disease, right? And also to identify restrictive lung disease. So I can't speak to you extensively about all the aspects of spirometry, but what I can tell you is, so this is the basic flow volume loop that we get from spirometry. Right, and this is the first chart is what we call the volume time curve. Right, so these are the two curves that you get from a basic spirometry report. And as Dilesha mentioned, the values that we see in the values that we obtain from spirometry are essentially unchanged. So FVC, FEV1, peak expiratory flow, FEV1 over FVC index, most of it remains unchanged, if at all very modestly increased. Okay, and another thing that I would like to tell you, that this is a non-invasive test. It can be performed safely in a pregnant woman, right? So it is not contraindicated. So there are worries because you have to perform a Valsalva maneuver. Is it safe to perform in pregnancy? It's absolutely safe, and you can actually interpret it, right? So this is a useful tool. So whenever you are in doubt, use it. And also diffusion capacity. For those who are not familiar with it, so this is where we use carbon monoxide to find out the diffusing capacity of the lung parenchyma. So if I tell you the basics of restrictive lung disease, some restrictive lung diseases are due to intrinsic parenchymal problems, parenchymal issues like interstitial lung disease, right? So in such instances, the diffusion capacity helps us a lot to tell us that there is something wrong with the lung parenchyma, and also to quantify it. And if you have patients with interstitial lung disease, this is also a very useful monitoring tool. So DLCO is not contraindicated in pregnancy, and we can perform it. Right. So arterial blood gas. So Dilesha has told you all about the changes in arterial blood gas. So because of the increase in minute ventilation and with the matched rise in the pulmonary circulation, there is an element of increased PO2 and a drop in PCO2 during pregnancy. So the increase in oxygen is not so much, it's actually quite minimum. But the drop in PCO2 is very significant. It goes down to about 28 to 32. So why is this important? One thing, it can mask underlying respiratory disease, right? So we have seen patients who have early type 2 respiratory failure who have actually normalized their blood gases during pregnancy, right? But towards the third trimester, again, because of the gravid uterus, they go back into that type 2 respiratory failure. But at the initial stages, you can miss it, right? A mild respiratory alkalosis is normal, and there's a compensatory drop in bicarbonate. So early signs of ventilatory compromised may be missed. So in a patient presenting with severe dyspnea, if you see a normal CO2, that can actually alert you that this lady is going to deteriorate soon. Right, so this is the main point that I want to tell you. Chest X-ray is safe. Please, please, please take X-rays whenever you are in doubt about whether this is something wrong. Okay? So fetal radiation exposure with a plain chest X-ray with shielding is very minimal, 0.002 milligram. Okay, so it's only slightly higher than the background radiation. So it's equal to just 1 week of background radiation. So the risks versus benefit. So benefit is much more than the risk. When yesterday we actually discussed a maternal death where a diaphragmatic hernia was missed because an X-ray was not taken. Right. So this is again another table about the fetal radiation exposure with regard to different radiological investigations. So as you can see, so if you move down to the area where there's CTs, even chest CT, the exposure is quite minimum. 0.01 to 0.66 as opposed to abdominal radiography, right? So abdominal radiography, there's quite a high fetal radiation dose, but CT chest still remains quite low. Okay, so as you know, ultrasound and MRI are the preferred modes of imaging in pregnancy, but the uses of these modalities with respiratory disease is quite minimal. Ultrasound is useful in terms of assessing effusions and things like that, but to get an overall assessment, we need proper imaging, X-ray and CT, right? So the radiation exposure is there, but it is an acceptable risk considering the diagnostic benefit of doing a CT in a breathless patient in the appropriate clinical context. I'm not asking you to do CT in every breathless patient that comes. So that's where the history and examination helps you. Right. Okay, then the age-old question, CTPA versus VQ scan. So pulmonary embolism is the thing that most people are worried about when a patient comes with severe breathlessness. And the safety of these two modalities, more than the safety, actually what comes into play usually is the availability. And availability, and in that term, CTPA has an advantage. So one thing you can do to reduce exposure to this radiation risk is to go for a duplex scan at the first instance, right? So if the duplex scan is positive for DVT, even if your suspicion is pulmonary embolism, your management won't change there onwards. The patient needs anticoagulation, so you can just go ahead with anticoagulation. But when there is absence of lower limb DVT, you have to do a CTPA or a VQ scan, right? So that is what is mentioned in this as well, in the RCOG recommendation. So the advantage of CTPA is it is readily available and it's more sensitive to detecting peripheral lesions. And it should always be used in instances where the chest X-ray is abnormal to start off with. And it provides additional information regarding the lung parenchyma, which us as respiratory physicians, that's why we're so fond of CTPA, because it gives us a good image of the lung parenchyma as well. So the disadvantage, most people think it's due to fetal radiation, but it's not. It's because of increased long-term risk of breast cancer due to rapid mammillary growth and extensive mitosis during pregnancy. But if you consider the absolute risk, it is quite low. And if you are encountered with a patient in whom treating pulmonary embolism can be life-saving, the advantage of arriving at a diagnosis absolutely outweighs the risk. Right. So VQ scan. So VQ scan is the ventilation perfusion scan. So we do this with radioisotopes. So in pregnancy, to reduce the risk of radiation exposure, we can go for a perfusion-only study, which has 150 times lower risk of radiation to the maternal breast, right? But if you compare the two investigations, the radiation risk to the fetus is slightly higher in a VQ scan as opposed to a CTPA. Right. D-dimer. So D-dimer is a tool that is used to exclude DVT or PE during pregnancy. Not pregnancy, in any patient, literally. So what is the use in pregnancy? So in pregnancy, the D-dimer level increases throughout. And if you see this in this study, 99% of pregnant women had a D-dimer level above the conventional cutoff point. So the utility of D-dimer to exclude DVT or pulmonary embolism in pregnancies is very, very low. Right? If it's negative, fine, but if it's positive, then again you're nowhere. So if you have a high clinical suspicion, just go for a CTPA or a VQ scan straight away. So these are my take-home messages. Chest X-ray is safe in pregnancy. Please counsel your patients appropriately. It's in our hands. If you tell them there's a risk to the baby, they will not go ahead with it. So counsel them appropriately. Spirometry can be performed and interpreted in pregnancy. And imaging is essential when clinical suspicion of pulmonary embolism is high and benefits outweigh the risk. Thank you very much.
Thank you, Sachini. Our next is the interesting case discussion. So we've discussed thoroughly about breathlessness in pregnancy. So to have the case discussion, to present the case, I would like to invite one of the few vibrant registrars at the Colombo Prof Unit, Dr. Dilini Disanayaka. So she'll present the brief case, and then we will have Dr. Bodhika from a consultant respiratory physician from this Nigambu General Hospital, who will be answering the questions. Yeah, over to you, Dilli.
Good morning, everyone. Thank you for that introduction, sir. I'm Dr. Dilini, currently working as a registrar at Prof Unit DMH. So I'll be presenting a brief case scenario for the discussion regarding asthma in pregnancy, which I think is commonly encountered in our day-to-day practice. So this is regarding Mrs. CD, 32-year-old patient from Paliagoda. She is a primary and known asthmatic since childhood and was on salbutamol MDI as required since 5 years. She came to our clinic at a POA of 9 weeks plus 2 days with dry intermittent cough for 5 days, which was worsening and developed shortness of breath since 5 hours. And otherwise, she was antenatally uncomplicated and no significant allergic and surgical history. On examination, her BMI was 25 kilograms per square meter and she was dyspneic, not pale or cyanosed. Temperature was 36.5 and GCS was 15 out of 15. Pulse rate was 112 beats per minute, blood pressure 126 by 80 millimeters of mercury. Saturation was 92% on air and respiratory rate was 27 breaths per minute. On examination, the respiratory system, there were bilateral bronchi, and on cardiovascular examination, there were no murmurs, and abdomen was soft and non-tender. These were the investigations. Full blood count, HB was 11.5, platelet is 307, and WBC was 13,000, CRP was 13, and ECG was normal.
Okay, so I'd like to invite Dr. Bodhika Savanayak. I'm very brave today as an obstetrician because when I see this patient, all these respiratory physicians are there to help me. So, Dr. Bodhika, my first question is, what is the initial differential diagnosis you would consider? So, when this patient comes to you, what would you think of?
Let me first thank both colleges for inviting me for this interesting session. Thank you very much. So this patient who presented with cough and shortness of breath for about 5 days duration and with a history of bronchial asthma in childhood, and there's a very important part in the history that patient was on salbutamol. I'll tell you why later on, that she was only on salbutamol inhaler. So she came with the exacerbation and CRP was a little high, and also there were bilateral bronchi. So considering all, my obvious differential diagnosis is bronchial asthma. So we have to first consider bronchial asthma here. And even without that CRP is even the lower respiratory tract infection can also cause some bronchospasms. and these patients upper airway dysfunction and allergic bronchopulmonary aspergillosis can present with shortness of breath and some unexamination bronchi. And pulmonary thromboembolism also need to be excluded in acute presentation of shortness of breath. So this patient, I first consider asthma, and so we need to assess this patient's, this is involved patient actually that I took this primary care algorithm, but this patient is the respiratory rate less than 30 and the pulse rate in between 120 and saturation in between 90 to 95. So then this is probably mild to moderate asthma. So if it is severe, you will get respiratory rate more than 30 and accessory muscles are used and pulse rate more than 120 and saturation would be less than 90. And we have to keep in mind the features of life-threatening asthma as well. They are drowsy, confused, and silent chest. So this is basically, even though in the hospital, like it is like mild to moderate exacerbation. So in this patient, you need to treat with the bronchodilators, like salbutamol. Since this patient is in hospital, nebulizing salbutamol is 0.5 to 1 ml with normal saline 2.5 with oxygen is the initial management, and we have to give the control oxygen for this patient, and also loading with steroid is needed for initial management. Continue this treatment, and we have to assess the response. If not responding, that we need to send for a higher care, which will be discussed in our critical care symposium later on. So these patients, I think our previous speakers discussed, but the peak flow plays a big role in managing asthma in hospital as well as in your clinic. So it is like a thermometer for asthma, diagnosis of asthma and measuring the effectiveness of medications, and also determine the severity of exacerbation. So if it is more than over 80, it's mild, and 60 to 80, it's moderate, and less than severe, it can be 60, less than 60% of predicted value.
Right. So thank you, Dr. Bodhika. So I think I'd like to pose the next question, and I suggest the audience to think what you would do if you meet this patient in your clinic setup. So once her acute condition is sorted and it's settled, how will you continue the management, or what will be her long-term management, and during the course of the pregnancy, because she's still at 9 weeks, to the remainder of the pregnancy, how will you manage her?
Well, very good question. So most important things like in this patient, so previous speakers discussed that chronic airway disease assessment. I don't want to go on details, but spirometry and blood test and all are needed, even in the pregnancy. But if she comes with exacerbation, so chronic management is important, even the first, second, or third trimester. So our question is it safe to use medications? So women with asthma who are pregnant or planning pregnancy should be advised not to stop ICS containing therapy. That is why the history I pointed out that this patient previously on salbutamol only inhaler, the guidelines now been changed. So it is important not to stop ICS treatment in these patients. So people are a bit reluctant to get the inhalers, especially in pregnancy, they worried about their child. And so, but ICS, beta agonists, short-acting or long-acting, Montelukast, theophylline are not associated with increased risk of fetal abnormality. So these drugs can be safely used in pregnancy. Evidence of, unresponsive asthma, complicated asthma, we refer usually for the biologic therapies, which is unfortunately not available in Sri Lanka, but I wanted to talk about that also. Evidence of biologic therapy during pregnancy is scarce, so that is also, if you have to, we have to weigh the risk and benefit and multidisciplinary team effort discussion, and so we can decide whether go ahead with biologics. So asthma guidelines, this is like, 2017, this guideline, so 2017, if you could appreciate here, usually in mild asthma, step 1, patients were put on like salbutamol only, like SABA, short-acting beta-2 agonist in previous guidelines, and also previous practice was that. So initially, lot of patients were on salbutamol as when required inhalers. So there is a fundamental change in asthma in 2019. So treatment of asthma with short-acting bronchodilators alone is no longer recommended for adults and adolescents. This is true for the pregnancy as well. So it is very important to treat with the steroid inhalers for management of asthma, because you know that asthma is an inflammatory disease, so your airways are inflamed and thickened, and so we need to treat the inflammation to control the asthma. So it is important to treat these patients correctly with inhaled corticosteroid, which are very, very safe. So why not treat with inhaled short-acting beta agonists alone? So SABA treats the symptoms but not the disease. So you need to treat the disease that you need steroid. So inhaled steroid, corticosteroid are very safe. So people with apparently mild asthma can have severe and fatal exacerbations. So about 27% asthma deaths are in patients with occasional symptoms. So this is very important. These people are like, patients with about 27% with occasional symptoms. They are mostly on short-acting beta agonists, salbutamol inhalers. So exacerbation triggers are unpredictable, and regular use of SABA, even 1 to 2 weeks, is associated with increased risk of airway hyperresponsiveness, reduced bronchodilator effect, and increased allergic response, and increased eosinophils. So starting treatment with SABA trains the patient to regard it as a primary asthma treatment. So when they relieve with the SABA, salbutamol inhalers, they don't worry about to take the ICS, and so that won't treat the cause. So there is strong evidence for more effective and safe alternative than SABA alone. So as needed ICS formoterol is recommended in these patients. So as needed only ICS formoterol reduced the emergency visits and hospitalization. So emergency visits by 65% and hospitalization 37% if you use ICS formoterol instead of simple salbutamol inhaler. As needed low dose ICS formoterol in mild asthma compared with an as needed SABA, risk of severe exacerbation reduced 60 to 64%. These are some results of Sigma 1 study that there's a rate of severe exacerbation reduced by 64% in the group which use budesonide formoterol groups compared with the SABA. So that is why now they have changed the guideline in 2022. This is the 2024 update. So step 1 and 2, they have recommended as needed only low dose ICS formoterol. So this is very important. Previously they used salbutamol for step 1. Now they change as controller, as a reliever, for both purposes. We are using now ICS formoterol combination. So that make a big change in management of chronic asthma. So alternatively, still, if you don't have formoterol combinations, take ICS. But when you are taking when you are taking SABA, salbutamol inhaler, take ICS when you are taking that, right? So always you have to combine with a steroid inhaler. So step 1 and 2, as needed and low dose ICS formoterol as a reliever. So only one inhaler, one advantage is that, and use as needed. So step 3, low dose maintenance and relief therapy, that's called MART therapy. Same inhaler, take one inhalation once or twice daily, and so as a reliever you can take one puff as needed. So like that you can increase the inhalations in steps, and if not responding, then we need to refer these patients for expert assessment, phenotyping, and add-on treatment. So if the patients are having daily symptoms, waking at night once a week or more, low lung functions, you can start with medium dose ICS formoterol maintenance and also ICS formoterol as a reliever. So symptoms most days or waking at night once a week or more, or low lung functions, then low dose ICS and formoterol combination as a maintenance and reliever. So symptoms less than 3 to 5 times days a week with normal lung functions, then we start with step 1 as needed, only low dose ICS formoterol combination. So the fundamental change is now instead of salbutamol, we use a combination therapy, ICS formoterol, from the beginning of management of asthma. So that is applicable for pregnancy as well.
Thank you, Bodhika. So then, that was a really comprehensive answer, and I think the main message was clearly put across to start not only short-acting beta agonists, but a combination with inhaled steroids. So my next question, I won't talk about labor that much because during labor, the steroid secretion is more, and the chance of getting an asthma exacerbation is a little bit less. So I want to know, if you have time, we'll ask about those questions later, but I would want to know postpartum, so after delivery, if there's an exacerbation, what will be the management in her case, especially because sometimes after cesarean sections, the patient might find it difficult having the optimal amount of breathing and all that, mobilizing and all that. With all those, will there be anything changing in the management postpartum, and she's breastfeeding and all that?
Well, that's a very good question. So we should keep in mind asthma is a life-threatening illness. So that is, we have to always keep in mind. People often forgetting that, but in postpartum also, it is important to manage your disease like with inhalers. So you have to continue, and physicians or obstetrician can review the patient. If less symptoms, we need to review these patients very frequently, and less symptoms, then we can go down, step down in the treatment. So asthma is stepping up and stepping down always. So asthma control should be assessed in a clear way. So that is why we need to assess these patients, and inhaled corticosteroid should be continued. But when the time comes, we can step down the treatment. So asthma treatment is not set and forget, and not just medication. So you need to confirm the diagnosis and symptom and control, and assess the comorbidities also. There are many comorbidities of asthma, and like, allergic rhinitis, we often forgetting, GORD, OSA. There are many comorbidities that we need to assess, and we need to treat that also, and always assess the inhaler technique. It is our duty as doctors. So always our visits, like, need to assess the inhaler technique of the patients, because in even European studies, like, they have shown that around 33% of patients are not doing the inhalers techniques correctly. So we can imagine our population. So sometimes, like, each and every time, we need to assess the inhaler techniques of these patients. And so it is a circle of assess, adjust, and review. So treatment of modifiable risk factors and comorbidities is important. So non-pharmacological strategies like weight reduction and sometimes nutrition, asthma medication including ICS, and education and skill training, and review the patients, and wherever necessary, that you have to repeat the lung function in these patients. So what we use is the 4 C's. It is important to, in your patients, it is important to select the correct, choose the correct inhaler. So patients' preferences are different and their abilities are different. So whether we need a dry powder inhaler or MDI, or a MDI with a spacer. So you need to assess these patients' abilities to take and choose accordingly, and check the inhaler technique and correct the inhaler technique, and also confirm the in each and every visit. So this is very important. And on the other hand, like, we need to, some patients are carrying a lot of myths, like, they think that one thing we already discussed, that inhaled corticosteroids are harmful to baby, and that's a myth. So you have to correct the myths. And other thing is antibiotics are very wrongly used in our country. So for asthma per se, like, asthma management, usually antibiotics are not indicated unless there is infection. But we see most of our patients, when there's a simple exacerbation, they are put on a lot of antibiotics, and unfortunately, very high antibiotics like levofloxacin, which is a second line anti-TB drug. So we are doing harm to the society like this. So we have to educate our juniors and doctors on antibiotic policies, especially in asthma.
Okay, final question, Dr. Bodhika. So before an asthmatic patient becomes pregnant, as pre-pregnancy counseling, what would you advise?
So when a patient is having asthma, so pre-pregnancy, they have to continue the inhaled corticosteroid throughout the pregnancy. They have to control asthma very well. Asthma is a life-threatening illness, so we have to keep in that mind. And we often forgetting to educate our patients on risk factors, triggering factors of asthma, dust mites, animal dander. Most of these people are having pets, pollens, molds, and some the cigarette smoking also now a problem. We have seen now, even in the Sri Lanka, our society also, the females are, increasing number of females are smoking these days and vaping. So these things you need to address and advise them properly. And don't forget about the flu vaccine again. So the vaccination is important to prevent, because these we have seen that severe pneumonias due to influenza and COVID, and people are still reluctant to get vaccines at the correct time. Thank you.
Thank you, Dr. Bodhika. So that concludes our case discussion and our session on breathlessness. So we have 10 minutes left for questions. So I would invite the audience, if you have any questions, make use of this opportunity to clear any doubts or clarifications you have with regards to breathlessness in pregnancy.
Good morning. I'm Dr. Asoka Virakko, retired obstetrician. A question to the panel. Have I understood this correctly? If somebody has got asthma, you treat the asthma depending on severity and not too much worried about whether they are pregnant or not, whether they are lactating or not. You treat the asthma as it is. Is that correct?
Yeah. Thank you very much, sir. That interesting question. Because now they have proven that in asthma, during the pregnancy, it should be controlled very well. And even the lactating mothers, like these steroid inhalers are not contraindicated. So the pregnancy that as a normal, you should consider as a normal patient. So asthma need to be controlled very well. Inhaled corticosteroid are indicated in all trimesters if they have asthma, and also postpartum and breastfeeding.
So just to add to that, there are a few studies earlier which showed that if you have a poor control in asthma, the risks are more to the mother and the baby compared to if you give the treatment. So initially there were some concerns about, I think Camilla mentioned about cleft lip with steroids and all that, but those myths have now been refuted by much more larger studies. So at the moment I think it's much better to treat the asthma, get it under control, because if uncontrolled asthma, there's risk of preterm labor and all those risks are there.
Because inhalers we are giving very small dose of steroids, so they are going directly to the lungs, so in the blood it is very less, so side effects are very, very low with inhaled corticosteroid.
Just to add to that, even oral steroids, when indicated, can be given, and prednisolone, there's the crossing of the placental barrier is very minimum, whereas betamethasone and dexamethasone, they cross the placental barrier, but for prednisolone and hydrocortisone, it's very minimum.
Thank you, sir, for that question.
This question is to the panel. If this patient comes to the ward with an exacerbation, would you do a chest X-ray or not?
Yes, please do. Okay, so so again, depends on the clinical context, right? So if it's a mild exacerbation and There's bilateral V's. She has obviously been off the inhaler. And then she responds to the nebulized medication, then no. But if it is a severe exacerbation and then you really need to rule out the possibility of an underlying pneumothorax or a consolidation. Okay? So in that appropriate clinical context, yes, absolutely. Right? So, when it comes to chest X-ray, I think we need to change our mindset, right? If you would do a chest X-ray if that patient was not pregnant, right, then just go ahead with a shield. With a shield, the exposure risk is minimal, right? So I think it's about changing the mindset regarding chest X-ray. It's okay to take one step back compared to a normal patient. But I think we're just running away from chest X-ray, which is what we have to change.
The question is because now from our teachers, now when we did chest X-rays, they asked, why did you do the chest X-ray? Not in pregnancy, I mean, in all patients. Because if you suspect consolidation, it's obvious on your clinical ground. So why did you do the chest X-ray?
Yeah, it's not always obvious, especially in pregnancy, right? So when you do respiratory medicine, more and more you understand that so history is very important, gives us 90% of the clues. Examination does not always provide us the information that we want. In pregnancy with the gravid uterus, and some patients are quite frankly obese, there are many lung signs that you will miss. And in the subsequent symposia also we will discuss changes of TB, changes of atypical pneumonia. The lung signs and X-rays vary, like there's such a discrepancy, right? So we absolutely need imaging in ill patients. If it's a simple asthma exacerbation, then no, right? But if things are not going as well as we would like, then definitely we need imaging.
It all depends on the clinical context.
Exactly.
Thank you for that question. Yes, that's one of the take-home messages from this symposium. Actually, we have seen patients who have been treated with inhalers for months and months in pregnancy to find out the patient is having TB at the end. There are patients with mediastinal lymph nodes, lymphomas developing in pregnancy who has not been investigated. So if the patient is not responding, you might, if the history is classical, you might treat for about maybe a few weeks or maximum 1 month. But if not responding, yes, please go ahead with the X-rays and other investigations.
So you were talking about antibiotics and misuse. So in an asthmatic patient, when will you decide on starting antibiotics? Is it based on her lung signs, whether she's having crepitations or CRP, fever, or which point will you decide on antibiotics?
Yeah, very good question. We need to assess, as I told earlier, that we need to assess clinically, and this patient is having fever and CRP is high, rising, repeatedly high, and then clinical signs are there. Then there is an indication for antibiotic use. But appropriately, we don't have to delay as well, so we need to assess these patients frequently. Then we have to identify what is the correct time to start antibiotic on these patients.
Thank you, sir.
Just a comment, the new asthma, the change of practice. So I mean, for the the new the junior doctors and all that, it's for me it was surprising. One of the commonest diseases in respiratory have been an ancient disease, and so to say that for the last more than 100 years we have been treating it wrong, and it shows the importance of research, and also that the chain of practice now, as all of us has been taught, you have to step up in salbutamol and all that way. Now suddenly there's a new practice. So this says why we should update ourselves all the time, and why these kind of symposiums helps us. And any thought why this took so long to change this practice from the respiratory point of view?
Actually, we have been also practicing wrongly this because I think many things for over the years, patients been responded to salbutamol. the clinicians were happy and the patients were happy that all their clinical features responded to salbutamol. So, I mean, they haven't paid much attention on that. But when steroid comes to practices, many studies done, and then they have proved that you need, because fundamentally that airway inflammation need to be treated. Salbutamol is just a bronchodilator. So that's how it comes. Thank you.
So can I just comment? I think it is basically because of the pathophysiological process, as the Bodhika said. It was mainly understood around the 1960s that is basically the inflammatory process that is going on. But we really needed studies to back up the recommendations, because if we don't have the studies to back up it, I don't think we can make recommendations. That is why it took GINA until about 2019 to change this practice. Until then, as Bodhika correctly showed, 2017 also shows salbutamol only. So that is the importance, as you suggested, the having the research as well as having updated conversations like this amongst ourselves, so that we can get updated on various diseases. I think, Dilesh, just a question now. We know that the residual volume reduces in pregnancy, right? And you said that it is because of the collapse of the airways. So if you do a total lung capacity in a different way, will it be affected, the residual volumes, the functional residual capacities?
So the functional residual capacity reduction is due to the collapse. Yeah. So the residual volume reduction also is one is that, the other is because the abdomen, the diaphragm is being pushed up. So those two factors are causing a reduction in the the residual volume. But when it comes to the total lung capacity, because the anteroposterior diameter increases in compensation of that, just to maintain an adequate total lung capacity. But then another reason why the residual volume is pushed down is because the patient starts hyperventilating. When the tidal volume increases, your inspiratory capacity increases, and then because of all those combinations, again there is less residual volume left in your lung.
I was just thinking now, because there is airway closure, you expect a little bit of air to be trapped in the lung, isn't it, rather than the other way around.
Yes, but I think it's the transpulmonary pressure which is reducing. So the transpulmonary pressure, when it reduces, it is not the collapse because of the air trapping and not the dynamic air collapse, but it is because of the reduction in the transpulmonary pressure, which causes a reduction in the residual volume and the collapse of the airways.
Thank you very much.
Okay, right. So thank you. I think our time is up for questions. I just have two questions. I expect a really short answer. One thing is there a point for eosinophil count when we look at the full blood count when we are checking for asthmatic patient? And the second question is, postpartum, most of the time we give diclofenac sodium for patients, and sometimes we forget the fact that patient had asthma. And I've seen it numerous occasions where it's been just prescribed routinely. So are all asthmatic patients sensitive to NSAIDs, or is it safe to give it? Yeah. And then we'll conclude probably. Yeah. Just a short answer, please.
Yeah. So about eosinophil count, yes, it's useful. It's a very useful investigation. It's not elevated in all, not all patients have eosinophilic asthma, but asthma is actually quite difficult to diagnose in anyone, not just in pregnancy. So you can only get clues from here and there, and then just patch it up and come to the diagnosis. So if there is eosinophilia, that is supportive. So we would always do a full blood count. So non-invasive and very safe to do. So why not? And about NSAIDs, would you like?
NSAID sensitivity is there, but to my experience, I'm not sure whether it's. But most patients we can give NSAID. It's not like all patients are sensitive to NSAIDs. There's a subset of patients who might not tolerate NSAIDs. So that's, I think that would be the answer for that. Yeah, there are different. Yes, when you talk about asthma, there are different phenotypes. So there actually now there's a lot of talks about asthma phenotypes. So it's a subset of patients who are sensitive to NSAIDs.
My question is, like, we use labetalol, IV or even oral, for especially in emergency, like emergency hypertension. In the asthmatic, we usually tend to give hydralazine. That's one, and the second one is also misoprostol for miscarriage management and for postpartum hemorrhage and all that. And again, when they have asthma, we are a bit reluctant to use them. What are your thoughts?
My personal experience with misoprostol is nasty. So when they do cause bronchospasms, it's quite bad. I think do you have alternatives for management?
Not for my PPH, yes, but for the miscarriages, then we have to go for a ERPC or something like that.
Yeah, I don't think it's absolutely contraindicated. But if the patient has a history of like brittle asthma or poorly controlled asthma, I think you really need to take precautions, because sometimes you give very high doses, don't you, for like PPH.
1,000 micrograms.
Exactly.
PR.
So my last experience was with that. It was terrible. Don't want to have that happening again. With regards to labetalol, again, it is, I think, if I remember right, fairly cardiac specific, but it can cause bronchospasms. So I think going for hydralazine as a first option is a better idea. But if it doesn't respond, then at that stage, I think you can try labetalol and see.
Thank you.
Just one last question.
Yeah, just one quick question. This is regarding chest X-ray. If you have a choice between chest X-ray and the ultrasound test, what would be the best in pregnancy?
Chest X-ray, because ultrasound gives us some information. Now there is, these critical care physicians, emergency physicians, they're all trained in point of care ultrasound, which gives us some idea about acute conditions which can present to the ED, right? So ultrasound is useful for us to evaluate pleural effusions, right? But chest X-ray gives us a holistic idea about the entire chest in one growth. So say things like tuberculosis, things like atypical pneumonia, you would not be able to diagnose mediastinal lymphadenopathy. None of it you will be able to diagnose with ultrasound. So and also remember that ultrasound is very much dependent on the person who's performing it. And unlike abdominal ultrasound, chest ultrasound is not something we routinely request for from the radiology department. So even there, there's not much training and experience. So chest X-ray, once taken, is there for anyone to see. So and it gives us a good idea about all three zones of the lung bilaterally. So and the mediastinum, fairly good idea. And then we can decide on whom to go for a CT. Okay, so I think chest X-ray, please.
So
thank you.
I think we'll conclude the session. Dr. Bodhiki, you want to add something? Yeah.
I would say like ultrasound is one of the important investigations in respiratory medicine nowadays, but it should be done by, as Sachin told, done by a expert who has a good training on that. It is very easy to identify a pleural effusion, large or small pleural effusion, but to identify pneumonia and other pathologies, like you have to do, it is time consuming, you have to do all the regions, and it is very time consuming to do a proper ultrasound. So it is very important in acute settings, but done by expert.
And urgently, I think ultrasound scan is a very, very good thing. We can identify the interstitial shadows, we can identify consolidations, pleural effusions, we can suspect pneumothorax, we can even suspect collapse as well to a certain extent if it done by an expert in the field, like the emergency physicians, critical care physicians, and the pulmonologists, as well as our internal medical colleagues who are trained on that. But as Sachini correctly said, some of these are masked and we might not be able to interpret it in a correct way. So always I think the chest X-ray is very important. And when you look at the medico-legal consequences of that as well, if you have not taken a chest X-ray and if later found that the patient is having a significant pathology in the lung, the person who has done the ultrasound might face legal problems as well. So, and the risk is very minimal, as Sachini said. So I think it would be better to go for X-ray unless there are significant compelling contraindications.
Right. Okay, so thank you everyone. I think we'll conclude the session. I would like to thank our esteemed panel for all the for their answering very to the point. And just to summarize the take-home messages, few things we highlighted was that chest X-ray is safe in pregnancy. If you feel it's indicated, you should go ahead with it. And also the change of the update of the new guidelines where you have to give inhaled corticosteroids along with formoterol as the first line therapy. So thank you everyone.
Indeed, this was an interesting and an informative session on a common concern in pregnancy. I'd like to thank the moderator and the panel of experts for their valuable contribution in making the first symposium a success. Now, let me cordially call upon Dr. Mangala Disanayaka, President, Sri Lanka College of Obstetricians and Gynaecologists, and Dr. Shamita Disanayaka, Consultant Physician, representing Sri Lanka College of Internal Medicine, to distribute the tokens of appreciation and certificates to the moderator and the panel of experts. Dr. Achinta Disanayaka, moderator for the session. Panel of experts, Dr. Amila Rubasinghe, Dr. Dilesha Vadasinghe, Professor Duminda Yasaratna, Dr. Sachini Senaviratna, Dr. Bodhika Samarasekara, thank you, sir.